need liver protection. The daily life overloads the liver, leading to the poor health and disease. People who are indulged in alcohol intake, coffee has got a better effect if it is taken in moderate amount. Poor nutrition or fasting, allergies, there are chemicals which can damage the liver, smoking, over-the-counter medications, psychological stress. All these things, they can lead some damage to the liver. Liver is one of the most important function of our body. It removes potentially toxin byproducts of certain medications. It prevents shortage of nutrients by storing vitamins, minerals, and sugar. It produces most of the proteins which are needed by the body. It produces bile, a compound which is needed to digest fat and to absorb vitamin A, D, E, and K. Produce most of the substances that regulate blood clotting. Helps your body fight infection by removing bacteria from the blood. It metabolizes or breaks down nutrients from the food to produce energy when needed. This is the summary of the liver function test, which we are going to talk about in detail in next slides. These are the traditional liver function tests: alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, gamma glutamyl transferase, total bilirubin, direct and indirect, total protein, albumin, AG ratio, and international normalized ratio. Why we do liver function test in our patient? Because they are sensitive, non-invasive method, just you draw the blood, and the pattern of the abnormal liver disease, liver functions can help us in making a diagnosis of the type of the disease. It has got a bit poor sensitivity, and sometimes it may not be able to give you a clear-cut picture. You have to use your clinical acumen in making a diagnosis. Interpretation of the liver function test. Contextualization. Liver interpretations must be contextualization for each individual patient. Different labs have different normal values, and a doctor must be knowing what are the normal values. And pattern provides specific causes of liver disease sometime and suggest the general category of the liver disorder, whether it is because of the damage to the liver cells, or it is because some damage to the biliary canaliculi, or something is abnormally produced in the body. So a doctor can interpret these abnormalities while looking into the liver function test. This is a chart which is just showing the normal and abnormal LFTs. When there is a hepatocellular damage, those enzymes which are stored into the hepatocytes, such as transaminases and lactate dehydrogenase, their level is increased. When there is a cholestasis, the alkaline phosphatase, gamma GT, and bilirubin and bile acids are increased. When the synthetic function of the liver is damaged, the PTN, INR, albumin, and cholesterol are the important parameters which help us in making a diagnosis. The metabolic function, bilirubin, ammonia, lactate, glucose, they help us in making a diagnosis. Clinical scoring of decompensation, that is Child-Pugh score and MELD score, help us in making our clinical or therapeutic interventions according to the disease and the stage of the patient. Hepatocellular damage. What are the markers of the hepatocellular damage? AST and ALT, they are related when the hepatocytes are damaged. Most of the labs, the normal value of the ALT is up to 40 and AST is up to 20. You have to know the pattern of AST ratio ALT, the level of elevation, and the rate of decline. All these investigations, all these patterns, they tell us about the disease process which is happening in our patient. ALT is mostly in cytosol. Its half-life is around 47 hours. It's very specific to liver. AST is mixed more in the cytosol as well as in the mitochondria. Half-life is around 17 hour when it is in the cytosol, and in mitochondria it is 7 hour. It is also released from the heart, from the red blood cells, from the pancreas, from gut, from the kidneys and lungs. So it's not very specific of liver. The normal ratio is 0.6 to 0.8. It means that most of the time AST is a bit low as compared to ALT. If it is more AST and less ALT, this is seen in cases of alcoholic hepatitis, in cases of patients who have got damage secondary to the drug, which is called DILI, extra hepatic sources, sometimes ischemia and cirrhosis. And in uh, Wilson disease, we can have more AST as compared to ALT. Now, if ALT is greater than 600, basically it is showing an acute hepatic injury. If ALT is less than 200, it could be seen in chronic hepatic injury. It can also be seen in an improving acute injury, and it can also be seen in a recent acute injury when the enzymes has just started elevating. Most of the time, we do get ALT level between 200 and 600, and then it all depends upon the clinical acumen of the physician to interpret this elevation. When ALT is greater than 600, most of the time is in acute viral hepatitis, and that could be because of common viral hepatotoxic viruses such as hepatitis A, hepatitis E, B. Hepatitis C is not usually associated with an acute hepatitis. Sometimes this much elevation is also seen in patients who have taken hepatotoxic drugs. Acetaminophen, ischemic hepatitis ischemic hepatitis is seen in a very critical state, and usually a patient are very toxic. Drugs such as anti-tuberculous drug, they can give rise to elevated transaminases. Autoimmune hepatitis must not be forgotten while you are interpreting liver function test of your patient, because sometimes they do present with abnormal liver function test and may not be manifesting the disease. Wilson's disease, similarly acute bile duct obstruction, and if there is a hepatic vein thrombosis, all of them, they can lead to the liver damage, and these patients will be presenting with an elevated ALT levels. So you can see that ALT is a marker which is showing that there is a damage to hepatocyte. But to make an exact cause, what is causing this damage, you have to do other investigations to end up to find out what's the basic pathology leading to this abnormality. In those patients, when we get a report of liver function test ALT less than 200, and it is not normal, it could be because of some chronic disease such as chronic hepatitis secondary to B or C. And this is the common scenario in our clinical setup, that when we see a patient of a chronic hepatitis, usually the ALT is around 2 to 3 times more than normal, and then we have to uh, find out what's wrong with it. In initial stages of acute viral hepatitis, when the ALT has started soaring up, we can have an ALT levels of less than 200. Must remember about NAFLD and NASH, because this is the disease which is now more common in wealthy countries as well as also in our country, as we are having more predilection to have a fatty liver, and these patients usually present with the ALT level of around 2 to 3 times normal. Autoimmune hepatitis, as I have already said, you must keep in mind metabolic disorder, hemochromatosis, alpha-1 antitrypsin deficiencies. They can also give rise to elevated ALT. AST is usually seen in liver diseases, is seen in alcohol disease. If it is more elevated than ALT, again, the more or less the differential is the same. It could be in cirrhosis, in NASH, in myopathy, strenuous exercises, hemolysis, and sometimes we can have macro AST as well. Rate of decline, it could be fast when a drug which has got a short half-life has damaged the liver. If patient has developed a coronary event or some ischemia to the liver secondary to some vascular disease, and then the revascularization has been done, an acute biliary tract obstruction which has been relieved with the intervention, fulminant hepatitis. Sometimes the patient who have got fulminant hepatitis, they show a rapid uh, rate of decline, and these are the patients when they recover completely. The rate of decline is low in those drugs which get accumulated in the liver when the damage to the liver is going on, such as a viral hepatitis or autoimmune hepatitis or metabolic disorder like hemochromatosis, when the process is going on, and similarly in the Wilson disease. So the rate of decline will remain there.